Hello, I'm Rahul, a junior doctor in the UK, and today I'll be discussing bundle branch blocks, both the criteria for diagnosis as well as the causes. Let's start off with a right-sided bundle branch block. Best way to learn this is by looking at V1 and V6. V1 effectively looks at the right side of the heart, V6 looks at the left side. Now we start off with atrial depolarization. The SA node fires and the atria depolarize. V1 we get a P wave and V6 we get a P wave. This is all normal so far. Next we get septal depolarization. And if you look closely, we get a small R wave in V1 and a small Q wave in V6. The reason why is the left bundle gives off terminal fibers in the septum. So therefore, the wave depolarization in the septum is from left to right. So V6 sees the wave of depolarization away from it, so we get a Q wave. V1 on the other hand sees the wave of depolarization towards it, so we get the small r. Now we move on to our first problem. The right bundle is blocked, so therefore the right ventricle doesn't depolarize. So the left ventricle depolarizes. Now, if you imagine if you're V1, you see the wave of depolarization away from you. So therefore you get an S wave. Whereas V6, the wave of depolarization is now towards you, so you get a large R. Now eventually the right ventricle does depolarize, just very slowly. So now effectively it's reversed. So the wave of depolarization is now towards the right. If you're V1, you now get an R wave. And if you're V6, you get an S wave because you see the wave of depolarization away from you. Now something important to note is the width. If you have a look at the width of this R wave in V1, it's quite wide. Same as this S wave in V6. And the reason why is this terminal component is very slow. It's all happening through muscle to muscle conduction, because remember this right bundle branch was blocked. So therefore you get a slurred S wave and you get a wide R prime wave in V1. Now let's put this all together and have a look at all the chest leads together. If you look closely, you see that on the right-sided chest leads, you see an RSR pattern, whereas on the left-sided ones, you get a deep slurred S wave. Now if we combine this together, we can come up with some criteria. So the most important one is that the QRS should be more than 120 milliseconds. The second criteria is that there should be an RSR pattern in V1. The third criteria is that there should be slurred S waves in the lateral leads. Remember, laterally refers to V5, V6, AVL and lead 1. And the last criteria is that the peak R time in V1, so R peak, is more than 50 milliseconds. And these together make our four main criteria. Now there are a couple of important small things I also have to mention. So the first one is that usually there are no ST changes in a right bundle branch block. The second one is that you do see some T-wave inversion. And usually the T-wave inversion is on the left side, sorry, it's on the right side. So you get the right chest leads. Whereas on the left-sided chest leads, the T-waves are perfectly upright. So as you see, V1, V2, V3, the T-waves are inverted. V4, V5, V6, the T-waves are all normal. Okay, so now what happens if it's less than 120 milliseconds? Remember I said the most important criteria was this one here. The QRS must be more than 120. If it's less, we call it an incomplete right bundle branch block. So first criteria, less than 120 milliseconds for the QRS. Second criteria is that there is an RSR pattern in V1, usually accompanied by T-wave inversion. If you get these two things together, we can call it an incomplete right bundle branch block. Now let's have a look at some causes of right bundle branch block, both incomplete and complete. So the first one we're going to call right ventricular hypertrophy. Second, atrial fibrillation. Third, PE. Fourth is an inferior MI. 5 is an anterior MI, and 6, occasionally you see it in patients without any pathology, structural pathology that is. Now this, if you remember, this is different to left bundle branch block. So right bundle branch block can often seen in without any structural heart disease. Left bundle branch block, usually you do see structural heart disease. So let's discuss a couple of these. So atrial fibrillation, the reason why you can often get an incomplete right bundle branch block in atrial fibrillation relies on this very important concept. So you have the left bundle branch and you have the right bundle branch. And effectively, the right one is very slow to repolarize. So if a P wave comes at the right time, it can find the left bundle branch open, where it finds the right one refractory. So therefore you get a slight widening of the QRS that can look like an incomplete right bundle branch block. Second one is PE, and PE is due to right ventricular dilation acutely. Fourth is inferior MI. Now with an inferior MI, essentially you get a very slow conduction in the ischemic right ventricle. With an anterior MI, you get left anterior descending artery occlusion, and this supplies the right bundle. And sixth, you can often see in normal patients. Now let's move on to left bundle branch blocks. Now we won't discuss how the waves come about, because essentially it's the opposite of a right bundle branch block. We'll start off with the criteria instead. So the first one, and the most important, is that the QRS should be more than 120 milliseconds. The second one is that there should be no Q waves laterally. And this makes perfect sense. If you think in the septum, the left bundle gives off terminal fibers, as you can see here. So therefore the normal septal depolarization of going from left to right doesn't happen, so you don't get these Q waves. So if you look here, V5 and V6 don't have any Q waves. Number 3 is a broad, notched or slurred R wave laterally. Now one important caveat I have to mention for criteria 2 is that occasionally you can see a Q wave in AVL, but you definitely shouldn't see any in V5 and V6. And 4, just like in a right bundle branch block, you have a peak R wave in V5, V6 of more than 60 milliseconds. This is a bit different to the right bundle, because in the right bundle it was a peak R wave of more than 50 milliseconds in V1. Now, just like the right bundle branch block, there's a couple of important things I have to mention. The first one is that unlike the right bundle branch block, you do see ST changes. Now, the ST changes and the T wave inversion is usually in the opposite direction to the QRS. So for example, in V1 you can see that the QRS is mainly negative, so therefore we get ST elevation and an upright T wave. In V5 we can clearly see we have an upright QRS, so therefore we get ST depression and T wave inversion. Now this does make assessing for a STEMI quite difficult, so we can use something called the modified Scarbossa criteria. And essentially with this one is, if the ST change is more than 25% of the preceding S wave, then we should be suspicious for an ST elevation. Now this relies on discordant elevation. So for example, V3 you can see is discordant because the QRS is mainly negative, but you have ST elevation. This is normal and we call this discordant. If you see this, use modified Scarbossa. Now if you have concordant ST changes, this is always abnormal. So for example, in V2, if you imagine instead we had a wave that looked something like this, where the QRS is mainly negative, but you had ST depression and you had T wave inversion, that's always abnormal. You should get this checked out. Now one other thing to note is that we have typical left bundle branch blocks and we have atypical bundle branch blocks. This is actually an example of atypical, because usually we should get a small R wave in V1. It should be very small. If it's not there, we should label it as an atypical left bundle branch block. Okay, so now let's move on to incomplete left bundle branch blocks. So what's the criteria? So again, the main one is that the QRS should be less than 120. So it should usually be between 100 and 120. The second one is that the R wave peak is more than 60 milliseconds in V6 or V5. And thirdly, we see no Q waves in the left precordial leads. If you see these three criteria, then we label it as an incomplete left bundle branch block. Okay, so now let's move on to causes of left bundle branch block. So as I mentioned, a right bundle branch block you can often see in patients without any structural heart disease. This is not the case for left bundle branch block. Usually you see it in one hypertrophy. 2, fibrosis. For example, Lev's disease, which is fibrosis due to aging. 3, we have ischemic heart disease. And 4, we have an anterior MI. Okay, so that's the end of this video. If you enjoyed the video, please subscribe as there'll be more content coming. Thank you for listening.